All right, here we go. Hello, everyone, and thank you for watching this presentation on new patient processing and insurance verification. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information in this presentation is for educational purposes. It's not intended to be legal advice. Target coding does not engage in providing legal services. If we talk about CPT codes, CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. A little bit about myself before we get started. My name is Dr. Marty Kotler. I am a chiropractor. I am also certified in CPT coding. I'm a certified professional compliance officer. I am the president of Target Coding. Target Coding has been around about 12 years. I've written many books on billing, coding, and documentation for chiropractors. I am a contributing author to Chiropractic Economics and Dynamic Chiropractic. I'm a featured speaker for the Coding Institute, Parker Seminars, and Foot Levelers. I've spoken to over 3,500 chiropractors and their staff members over the last 12 years at seminars across the country. I'm a guest speaker at many state association conventions. Those of you that are part of your state association that's looking for guest speaker on coding, HIPAA, compliance, documentation, let us know. We oftentimes can get a speaker to sponsor, a sponsor to sponsor my speaking events. So that could be very helpful for state associations. So that's a little bit about myself. So now we're talking about new patient processing. So when does it all start? It starts with the very first phone call. That's the first way that a patient contacts you most of the time. I know some of you can get walk-ins. People can walk in off the street, and that's the first interaction you have with the patient, but most of the time it is a phone call. So let's talk about the new patient telephone call. What should you do? What steps should be taken? What items should be gathered to make this go smoothly? Now, this new patient processing system that I'm talking about, other people call it onboarding. It's this process where a brand new patient comes into your practice and what steps need to be taken. This is a very important part, this onboarding situation, because if it's not set up properly, then everything else can get messed up. It's like the foundation of a house. If the foundation of the house is tilted, then the rest of the house will be tilted. You want to get this information, this introduction into your practice by this new patient to go smoothly. So now you get this phone call. My recommendation to front desk assistants is try and gather as much information as possible on the very first phone call without going overboard and making it too lengthy of a conversation. You want to be kind, you want to be efficient, you want to be caring on the phone. Remember, when a new patient calls, or when a new patient comes into interaction with your practice, it's not with the doctor. It's very rarely that the patient's interaction initially is with the doctor. It's typically with a front desk assistant, someone answering the phone. So your front desk CA should have a nice, pleasant approach and sound efficient and is going to get the job done and without taking too much time to get the information. So gather as much information as possible. In my opinion, the minimum, name, email, telephone number. I'll go over that in a few minutes why I think those three things should be the minimum. Some of you want to get address, you want to get more information, you want to get the chief complaint. Is that a good idea? Maybe, maybe not. Getting the chief complaint, if you say, okay, Mrs. Jones, welcome to the office. What seems to be your main problem? This new patient may spend a lot of unnecessary time explaining things to you, which could prolong this initial phone call. Again, you want this initial phone call to be pleasant, efficient, streamlined, get things done, be nice, but also be efficient and not have to spend too much time on the phone. Who referred the patient? That's a good question to ask. How did you find out about us, Mr. Williams? Do you ask about Finances, do you talk about money on the very first phone call? Most offices do. I think it's a good idea to do it just to get it out of the way. Some of the doctors I work with, they go, no, Marty, we don't talk about money at all on the very first phone call. We don't want to scare the patient away. We don't want to talk about finances because it could prevent the patient from coming in. Okay, well, if it's working, go with it. My feeling is, out of every 10 patients that call to make an appointment, how many actually show up? If 9 out of 10, 90% of the time patients are showing up, whatever the front desk assistant is saying on the phone, it's working. But I've worked with some clients where only 40 to 50% of the patients show up. A lot of shoppers, the front desk assistant is not doing a good job. I call it being the bridge. Front desk assistants need to be the bridge from the patient to the office. Whatever it takes, get that patient in the door. Once the patient is in the door and they're talking to the doctor and now the patient decides they don't want to come in anymore, it's not on the assistant. It's more on whatever else. Maybe the doctor. Maybe the patient didn't have a good connection with the doctor. But front desk CAs, you want to get the patient in the door. So now, again, back to money. Do you talk about finances on the very first phone call? You know what? Nowadays, if you don't bring up finances, oftentimes the patient will bring it up. But sometimes patients don't bring it up. Do you want to bring it up? I think it's a good idea to ask for insurance information. Again, there are pros and cons to it. You know, one of the negatives are if the patient says, you know what, I didn't realize, you know, that we would talk about money on the very first phone call. So Mrs. Jones might say, oh, you know what, are you in network with my plan? Will you accept my insurance? You know what, I'd like you to, you know, verify that I have coverage before I even come in. See how this could lead to that, but most of the time it's pretty straightforward. Now, the information that the patient is providing you with, right? The patient is giving you their name, their email, their telephone number. Front desk CAs, what are you doing with that information? Are you in real time while the patient is on the phone with you? Are you entering the information right into the system? To me, that's the most efficient way. It's the most, you know, it saves the most amount of time. If you can get that information in real time while the patient is telling you their name, their email, their telephone number, you're entering it into your, you know, your EHR system or whatever program you have, that's great. But some front desk CAs don't have that ability. They don't have that, you know, capability. So I've created a form where you could write a few things down. I call this the new patient phone call intake form. So for staff members that want to quickly jot down the information that the patient is providing you with on a piece of paper. Now I know we want to go paperless. I'm going to be talking to you about trying to go as paperless as possible. You know, it's much more efficient nowadays not to have paper. But sometimes you need to write things down. So this is my sample new patient phone call intake form. So for those staff members that are not able to enter the information in real time into the computer system, you might want to have a piece of paper right next to you. I don't know, appointment books, years ago we used to have these large appointment books on the front desk, and front desk CAs would enter the patient's information right into the appointment book. That got all sloppy. I don't see appointment books that often, but if you want to have a piece of paper right next to you to jot the things down and then enter it into your system, here's the form. You should see it on your screen. It has some basic information, but there's a couple of other things here that you should probably ask a new patient. It would be nice to gather this before they come in, but you should, if you don't have that opportunity, you should gather it when they do arrive. So, for example, is your condition related to any type of automobile accident or on-the-job injury? That's a very important thing to ask prior to the patient even coming in. I know, you know, most of my clients, and myself included, I wanted to know before I walked into the door if this was a Medicare patient, a cash patient, auto accident, work comp, in-network, out-of-network. It's not that it made that much of a difference on how I was going to treat the patient, but I just felt like It was something important for me to know. For example, if I'm going to walk into the room and it's just a cash patient, no insurance, the approach is different if I'm going to walk into the room where the patient has been in a severe car accident where they have multiple bodily injuries. You know, the approach, I have to set aside a little more time. I have to be prepared to dig a little deeper. So that's a very important question to ask. Is your condition related to any accident or injury? I highly recommend you ask that on the very first phone call. Also, have you seen any other doctors for your condition? Maybe if you have this patient referred to you by another healthcare provider for a consultation, that's possibly a different billing code. Does the patient need a referral? You know, that's a good question to ask too. Some patients need a referral from their PCP. So, but most of the questions are pretty straightforward. My feeling is name, telephone number, email. Now, why email? We'll get to that in a few minutes. So there's a sample phone call intake form. You could jot down the information quickly, enter it into the system, and then you could shred the paper. So now let's go through just a quick sample new patient phone script where Katie is the doctor's CA and Tom is the new patient. So, hello, Dr. Smith's office, Katie speaking. Can I help you? Yes, I'd like to make an appointment. Now, staff members, I know we have a lot of CAs listening to this presentation. A good question to ask at this point, if you're not familiar, like if a patient calls up and says, hi, I'd like to make an appointment, you know, the number on the caller ID doesn't look familiar. The voice doesn't sound familiar. And somebody says, hi, I'd like to make an appointment. How do you know, staff members, if this is a brand new patient or a patient that was in a couple of weeks ago? The best way to do it is say, when was the last time you saw the doctor? Tom says, I've never been to your office before. Bing, a bell should go off in the front desk CA's brain saying, okay, new patient, you got to go into new patient mode. Again, this is the patient's first impression of your office. If there's a lot of noise, if there's a lot of, you know, hold on, I'll be back with you, and the front desk CA doesn't seem focused, it's very negative approach on the new patient. So go into new patient mode by asking questions, simple choices. You want to control this conversation. Tom says, I've never been to your office before. Okay, we're going to new patient mode. No problem. When would you like to come in, today or tomorrow? Just give choices. If you say, when would you like to come in, Tom might start, you know, giving you days and times that you're not even in the office. Control the conversation. When would you like to come in, today or tomorrow? Tomorrow, great. Morning, afternoon, or evening? Afternoon. Okay, 3:30 or 4:30? 4:30, great. Just need a little information. How do you spell your last name? E-V-A-N-S. Can I have your address? Again, you might not want the address. Phone number, email. Now, the reason why I ask for email is because some of my clients will now, after they get the patient's appointment in the books, they ask for name, telephone number, and email, and that's it. They get the email. After the conversation is over, hang up, front desk CA emails the patient a welcome email to the practice where there's a link. And then that link, the patient clicks on it, and then the patient will create now a username and password, and now they've logged into your EHR. You could only do this if you have a certified EHR program, and there's quite a few really good ones in the chiropractic profession. So if you have one, you can do this where the patient now clicks on the email, the link in your email, and now it creates a username and password, and now they're entering in all of their information: name, address, phone number, social security number, insurance information, and you could have all of your assignment of benefits and financial policies, and all your different forms can be filled out that way. So that's the most efficient way, in my opinion, to get this done. But most offices are not at that point. So you're going to gather information, ask the patient, how did you find out about us? I saw your ad in the newspaper. Great, we get a lot of patients coming in from the ad. Now, what seems to be your main problem? Again, be careful with that. You might not want to ask that because that could open up a whole big conversation. Tom says, I have low back pain. Katie says, sorry to hear that. We should be able to help you. Dr. Smith has treated thousands of patients with low back pain over the last 8 years, gets tremendous results. So that's a good way to sell the sizzle, so to speak. You know, there are some patients that are shoppers. They're shopping around. So if you get that impression, and you might have to be doing this for a while as a front desk CA to have some experience where you can tell somebody's calling and they're a shopper, then you have to go into a little bit of selling the sizzle, so to speak. You got to promote the office. So be prepared for that. Remember, you want to get the patient in the door. So Katie says, great, we'll see you tomorrow at 4:30. Do you need directions? You know where we're located. Yeah, no, Tom says, I know where you're located. Now, it seems as though Tom is ready to hang up without discussing money, but Katie's not going to let that go. Katie says, great. Now, if you have insurance, that's if you have insurance, please bring your card with you. Will you be using insurance? Good question, right? Tom says, yes. Do you accept ABC insurance? Yes, we do. Great. Do you know how much it's going to cost? You see, now it can open up a can of worms with money, but my feeling is you might as well take care of it now. How much is it going to cost? Well, now the answer that your front desk receptionist should be giving is going to depend upon a couple of things. Whether are you in what is the ABC insurance plan? Are you in network with it? Are you out of network with it? Do you participate? So there's a couple of different answers. Well, here's the first one. Well, there are many different ABC insurance plans, so I'm not exactly sure how much the first visit will cost because we're out of network. Or, you know, if your condition is minor, it shouldn't cost that much, and now you can give a range. $50 to $150, depending upon what the problem is and how long the doctor needs to spend with you. Now, that conversation will change if you are in network and you know about this specific ABC insurance plan. So you could say, oh, yes, we're familiar with that plan. We are in network. Your copay will probably be between $25 to $40. Can you take out your card, Mr. Williams, and what does it say on the card under specialist? Is there a dollar amount? So you could ask the patient what that says, and that's typically going to be the copay if you're in network. But if you're out of network, you might say, well, now, because you have insurance, we're out of network, we do accept assignment, and you may be only responsible for a small portion. You know what we're going to do, Mr. Williams or Tom? When you come in, we're going to call your insurance company and find out what the coverage is. Sounds great. See you tomorrow. Goodbye. Now, there are a couple of other things that you should be aware of with this new patient phone call. The patient may want to know exactly what the copay is. If they say how much, I don't recommend you narrow it down to one amount. Just by you saying, oh, it's $40, the patient may think everything is $40, but your x-rays could be $150, right? So careful with that. Patients should realize your time is valuable. Some patients want to know what the coverage is before they even come in. So be prepared for all of that. Now we're going to go to the next step, the actual first visit. Brand new patient walks in the door. Staff members should be aware. You look at the schedule, you see a patient walk in at 10 o'clock. That's scheduled for 10 o'clock. This is an unfamiliar face. Boom, there you go. There's your hint. There's the new patient. Now the new patient comes into the office and they have to fill out forms. Now, if you have an EHR program where the patient could fill out the forms prior to coming in, that saves time. If you have a website where you could direct your patients to your website where they can click on your forms, if you have them on your website where the patient could download them, print them out, fill them out, and bring them in all completed, that's really nice too. Again, you always want to save time, right? Time is money. Save as much time as possible. So, but it's okay if the patient comes in and they fill out paper forms. Some of you give patients iPads or you put them in front of a kiosk where they're filling out the information digitally. That's fine too. Whatever it takes, get all this information out of the way. You got to get these forms filled out. If you want to use paper forms, clipboard, paper forms with a pen, that's fine too. Here are my suggested forms. A general health history form, financial policy, assignment of benefits. If it's a PI case, try to get the attorney to sign a lien or a letter of protection. Informed consent, get that from your malpractice company. Consent to treat minor, yes. Acknowledgement form for non-covered services. Medicare ABN forms if you see Medicare patients, outcome measurement forms like Roland Morris, Oswestry. It's a good way to monitor progress. A HIPAA notice, notice of privacy practices, that's mandatory. Every patient in your practice must see your HIPAA notice. And there might be some state-specific forms to your practice. So, just a general health history form. Most of my clients have very good forms. You can get them also online through companies like Medical Arts Press, Quill. There's Parker Seminars. There's a lot of companies that sell chiropractic intake forms. Here's one sample. This is a couple of forms I created for my clients. A review of systems form. Again, you want to get that out of the way. Here's the HIPAA notice. This is a very important form. It helps explain to the patient what HIPAA is, what their rights are, what your rights are. If they want to file a complaint, where they can file a complaint. I know that's not fun. It's like walking into a restaurant and them saying, here's a form, just in case you think we have a health violation or you see a bug in your food, here's a form where you can file a complaint with the health department. That wouldn't be a fun thing when you walk into a restaurant to see that. Well, in healthcare, yeah. If, this is part of HIPAA. If the patient feels that you have violated their HIPAA rights, that you're telling them where they can file a complaint. Yeah, I know, not fun, but these are the these are the rules. You need to know the rules, right? In order to know if you're breaking them or following them. So HIPAA notice, very important. They have the opportunity to get a copy. They have to. You have to list your compliance officer, the effective date of the notice, and the patient has to sign a form that they've had the opportunity to review the HIPAA notice, and if they want a copy of it. If for some reason they go, I'm not signing this, should you still treat the patient? Yeah, probably. This isn't a requirement. Typically, most patients, 99.99% will sign it, but if a patient says, I do not want to sign this, you should probably still take the patient, take that on a case-by-case basis, but then at the bottom of the form you have to note, patient has refused to sign the HIPAA notice. Okay, next, educating patients. Nowadays, it's become more important than ever to educate patients. You need to talk to patients more, than just about chiropractic and subluxation and misalignment and pinched nerves. You need to educate them about, if they have insurance, about the difference between medically necessary care, which is also known as reimbursable care, versus wellness care, which is also known as non-payable. So because some patients come in and they go, I called my insurance, I heard I have unlimited care. Really, that's not really the case. The patient forgot to say that it's unlimited as long as it's medically necessary. Or some patients come in and say, I called my insurance, I'm covered for 25 visits. Well, yes, that's up to 25 visits, again, as long as it's medically necessary. So educating the patients about the difference between medically necessary care and maintenance care is very important. I recommend you try and do that in the beginning of the care. If not the first visit, the second visit, or the third visit. Patients should understand they may not be able to use all their visits because if they get to the point where it's wellness or maintenance, it's not covered, so they should be made aware of it. Maybe the best time to do this is during the financial report of findings on the second visit to explain to the patient how it works with insurance. Again, it's more important nowadays. Most people think, my insurance is great, it covers unlimited care, and they don't realize that it's as long as it's medically necessary. During the financial report of findings, if staff members are doing, front desk CAs are doing the financial report of findings, you must be persistent. Because if you're not persistent, many times the doctor is not the best at talking to patients about money. Many doctors have the mindset, my goal is to get people well. I have staff members that are taking care of the finances. That's great. I understand it. So staff members, you need to be the pit bull. You need to be persistent and aggressive to get the payment for the services. Now, why should you get payment for services? Well, because you deserve to get paid for everything you do, right? Hopefully you have that approach. So staff members, you must be persistent. But you know what's funny? Doctors, when they look out into the waiting room, here's a little graphic here. Most doctors, when they look out into the waiting room and they see 6 patients sitting in the waiting room, they go, oh yeah, patient number 1, yeah, she has headaches. Patient number 2, shoulder problem. 3, sciatica. Patient number 4 has neck pain. And then knee bursitis. Oh yeah, there's Debbie. She has a herniated disc. That's what the doctor thinks when he or she looks out into the waiting room. What does the staff see? They see a different approach. Front desk CAs, they go, oh yeah, patient number 1, oh, we got to collect a $20 copay from her. Patient 2, use the 5 visits, we got to get pre-auth, we got to fill out a medical necessity review. Patient 3, oh, we billed that patient for a lumbar brace and it came back denied. Have to talk to the patient about that. Patient 4, Medicare patient, we need to get an ABN form signed today. Patient 5, credit card expired, we got to get an updated credit card. Patient 6, oh wow, I got to talk to the doctor because Cigna is waiting for the notes before they can pay us. Right? A lot of staff members, could definitely relate to this. Again, doctor sees patients and just sees conditions. Staff members, you need to get the doctor paid. Now, as far as payment goes, I've categorized it down into 10 categories. These 10 categories cover every single financial arrangement with every single patient you have in your practice. I think, I'm pretty sure. So you have cash patients that just pay, at the time of service. Then you have prompt pay discounts. You give patients discounts, a time of service discount. Some patients prepay. You have hardship. You have managed care where you're in network. And then you have some plans maybe you're out of network. Then there's Medicare, par and non-par. Personal injury, workers' comp, discount medical plan organizations like ChiroHealth USA. And then you have patients coming in with health savings accounts, health retirement accounts. Front desk, CAs, doctors, you have to master all 10 categories. Please do your best to do that. Now, a little bit about, coinsurance and copays. I know we have a lot of new staff members listening to this presentation, brand new to the chiropractic industry, that are not familiar what the difference is. A coinsurance typically represents a percentage that the patient is responsible to pay out of pocket. For example, patient has a 70-30 plan and your fee is $150, the patient would be responsible for $45. That's 30% of $150. Coinsurance usually applies to out-of-network providers. Copay is typically a flat fee. It's typically for in-network providers. Same example, your fee is $150, but the copay is $25. So the patient's only responsible to pay $25. The difference between the patient copay plus the insurance payment and your total bill must be written off. And then we have deductibles. Deductibles apply to in-network and out-of-network nowadays. It's the amount that must be paid prior to the insurance company paying for any items. Deductibles have increased over the years. And it's critical to collect your fees that the patient owes you. You shouldn't be embarrassed or ashamed to collect your fees. You're providing a valuable service. The more you waive payment, the more you're diminishing the value of your practice. Do not waive copays. It's not appropriate to waive copays, coinsurance, or deductibles. This could be interpreted as a fraudulent misrepresentation of your charges. Also, studies show that the chance of collecting from a patient almost drops 20% as soon as they leave the office. I still have some clients, I don't get it, where they're mailing patient statements. I don't think that's a good idea. Some offices, they find it easy to mail a patient a statement after each visit. Wow, that can cost anywhere from $5 to $10 per patient to send and process each statement by mail. Plus, once you mail the statement, you're decreasing your chances of receiving payment. Now, with your cash patients, I think it's a great idea to introduce them to a discount medical plan organization. There are a few out there, but the one I like the best is ChiroHealth USA. You join the network, you set the fee, you could substantially discount your fees without violating the dual fee schedule situation. excellent, it's an excellent alternative for patients. It's a pretty easy sell. Mrs. Jones comes in, well, Mrs. Jones, my normal fee is $150 per visit. Are you a member of Chiro Health USA? No, what's that? Well, if you become a member of Chiro Health USA, it's only $40 a visit. Really? Wow, that's a huge savings. Yeah, that's the arrangement we have with them, so patients will be very interested. It could work with Medicare patients, high deductibles. Now, let's talk a little bit about verification of coverage, insurance verification. In my opinion, there are 5 categories you need to cover when you're verifying coverage. First, E&M services like your new patient exams, re-exams, if you bill for coordination of care, counseling and coordination of care, team conferences. Next category, diagnostic tests. Most common in chiropractic, x-rays. There's also range of motion, muscle testing. There's surface EMG, needle EMG, dynamic EMG, tons of different tests. Next category, modalities and therapeutic procedures, very common in chiropractic, like traction and manual therapy and therapeutic exercises. Fourth category, obviously, chiropractic adjustments, spinal and extremity. And then I have a miscellaneous category. It's nice to verify coverage if the patient has a benefit for orthotics, back braces, DME, home traction, vitamins, pillows. And verification of insurance has changed over the years. Years ago, you would have to call just about every company. It's changed. There are outside companies that do this for you. There are automated systems. You can go online. For those of you that do not have any type of automated system and you're calling, this is the form I've created for target coding clients. It's very detailed. It gets into very, very specific questions. It gets into very specific coding. We really like to, if we're going to spend the time to call to verify coverage, we're going to try and get as much information as possible. We're going to, dig down deep. And an insurance verification phone call can take anywhere from 12 to 20 minutes. Staff members listening to this, you know what I'm talking about. You could relate to this. This is very time consuming. Sometimes doctors don't understand this. They don't realize how long it takes to do this. But once you get the information, it's very valuable. Get the person you're talking to, get their name, get their direct line, the time of the call, and go through all these questions. Deductible, carryover, lifetime max, out-of-pocket max, how many visits are covered. Regardless of what they say, if they go 20 visits are covered, say, you know what, if it's necessary to get the patient more visits, the patient needs more than 20, what do? They'll give you the information on that if they have a soft cap. So I've put this form together and separated out the benefits and the categories. Let's go through a quick sample script. So you call Katie, you're a front desk CA now, or office manager, or insurance CA. She's calling to verify coverage on Tom. So Jane works for the insurance company, says, hello, insurance, ABC Insurance, how can I help you? Hi, my name is Katie. I'm calling to verify benefits on a patient. Great. Could I have the patient's name and ID number? Yes, the patient's name is Tom Evans. Here's his ID number. And then they give you information. Oftentimes, you can get this prior to the live person even coming on the phone. It's an automated response where they tell you the deductible, individual, family, lifetime max. But now you want to dig a little deeper. How many visits are covered? Insurance company, Jane says 20 visits are covered per year. Is that 20 visits per condition or 20 visits per year total, regardless of how many conditions? It's 20 per year. Is there a dollar limit per visit or per year? No, fees are based on usual and customary. All right, a couple more questions. Dr. Smith performs very thorough exams. Is that covered? For example, 99213. Yes, exams are covered. Now, if Dr. Smith performs a re-exam, and that's the only service he renders, the 99213, does that count as one of the 20 visits? Oftentimes you'll hear, no, office visits do not count as a chiropractic visit. Great. What about x-rays and therapeutic procedures such as 97110? Does that count towards the 20 visits? X-rays do not count. All physical medicine and rehab do. Thanks. Just have a few more questions. Does the policy cover 98943 and 98951 and acupuncture? Jane says 98943 is covered. 95851 is based on medical necessity. 97810 is not covered. When you hear it's based on medical necessity, that's a good thing because you'll be able to prove medical necessity, hopefully. So that's actually a good response. I'd rather a health plan say, we cover it as long as it's medically necessary. I'd rather hear that than we only cover 5 visits. That's it. A little bit about financial policies. Written financial policies. Very important. It helps patients understand your office billing and collections procedures. Helps educate the patient about acute care versus chronic care versus wellness maintenance care. Gets patients to understand that they are responsible for a portion of the bill. You can have patients come into your office that have been to other chiropractors where the other office accepted insurance as payment in full. The patient didn't pay anything. And now they come to your office. They expect the same thing. That's the way they were trained. And now you're asking them to pay. It could be a little bit of an uncomfortable situation. Staff members, you need to be persistent and tell them what your policies are. It enhances communication with patients, and it prevents upsets if you have it in writing and explain it to the patient. Give them a copy so they have it. All right, just a few closing comments. Please check with all the carriers you bill prior to submitting claims based on this information. We can't guarantee that this information will guarantee payment from any carrier or patient. We're not responsible for any managed care or insurance company laws, rules, guidelines that may change following this presentation, and you know they always change. So do your best to stay on top of these changes by attending seminars, webinars, and joining your national and state professional associations. Here's our contact information. Email is info@targetcoding.com. Website, targetcoding.com. Telephone number, 1-800-270-7044. Our HIPAA secure fax number is 1-844-831-23447, 1-844-831-2347. Couple of things before we get to questions. A lot of doctors are asking us about OIG compliance. This is mandatory. If you see Medicare patients, it is required that you put together an OIG compliance manual. If you don't want to get one from us, get one from someone else. You need to do this. It's very important. Audits are on the rise. People are going to be knocking on your door asking you if you have policies and procedures, written policies and procedures. It's an easy little playbook you could put together. So OIG compliance. If you see Medicare, Medicaid, any federally funded program, you are required to have a compliance manual, and we offer it at Target Coding. Again, if you don't want to get it from us, get it from someone else. Our program is a little different. It's very customizable. We help you create your policies and procedures. We personalize them for your practice. We give you a chart audit tool. That's one of the most important parts of compliance, is that you have to do self-audits. You have to take out a couple of charts every few months and review them yourself and score them and grade them yourself. So we have a chart audit tool that we give you as part of our OIG compliance program. We give you sample logs and forms to fill out. Oh yeah, here's our chart audit tool. It's an Excel spreadsheet where we just have a whole bunch of questions. Is the patient's name on the form, date, the diagnosis, for the initial visit, areas of subluxation. We have a whole checklist, so this is something that we offer. We also have a comprehensive HIPAA program that we offer. It includes a comprehensive security risk analysis with detailed report and action plan, a cloud-based storage portal for all of your HIPAA policies and procedures, compliance training videos, testing with certificates of completion, business associate tracking. HIPAA, we include our OIG compliance program as part of the HIPAA program. OIG doesn't include HIPAA, but HIPAA includes OIG with our programs. And just to let you know, they're two totally different programs. OIG is all about preventing billing and coding errors. So when I talk to a doctor and I go, are you compliant? A lot of doctors go, yeah, Marty, we've taken your courses. We're members of Target Coding. We watch your videos. We're compliant. We bill right. We're using the right codes. We document properly. That's OIG. That has nothing to do with HIPAA. So OIG is about billing, coding, preventing fraud and abuse. HIPAA is about protecting patient health information. It's about protecting their data in your systems by using proper passwords, by training staff, by having backups if there's a disaster where you lose your information. So HIPAA is about protecting patient health information. OIG is about preventing billing and coding errors. I recommend this book. This is a book that I put together. The first edition was for many years with ICD-9, and then this is actually the third edition of my book on the best chiropractic ICD-10 and CPT codes to improve reimbursement. It includes many different sections on pairing your codes, on justifying the codes. For example, let's say, here, this is a page out of the book. Let's say a patient comes in with cervicobrachial syndrome. That is ICD-10 code M53.1, very common code used by chiropractors. If you are questioned, if somebody comes knocking on your door saying, hey, Dr. Kotler, we see that you diagnosed cervicobrachial syndrome. Could you explain how you came up with that? So we have it right here on these in this chapter of the book. Well, the patient had pain in the neck and down the arm. We did Wright's Atson's test. We did some neuro tests, like we checked for myotomal weakness and looked for diminished sensation. The patient had forward head posture and palpatory tenderness and subluxations. So you want to be able to provide anybody that's snooping around asking you about your diagnosis codes and how you came up with them. You want to be able to give good quality answers with the chiro, ortho, neuro tests to substantiate the code. We also have these cheat sheets that break down the long-term treatment diagnosis codes versus the short-term treatment diagnosis codes, and a little hierarchy. There's also a frequently asked questions section. Like a lot of chiropractors ask me, Marty, when I diagnose a patient, what's the difference between radiculitis and radiculopathy? What's the difference between radiculopathy and myelopathy? What's the difference between cervicobrachial syndrome and cervical radiculitis? What's the difference between idiopathic scoliosis and thoracogenic scoliosis? A whole bunch of FAQs. We also show you how to pair your procedure codes with your diagnosis codes, like you pair red wine with red meat. I show you how to pair your procedure codes and your diagnosis codes in the book. We also do seminars. We have tons of other free webinars. We have paid webinars. We have webinars where you get CE credits. We also offer memberships at Target Coding. We have something called our basic membership. It's $99 a month, pay as you go, no contract. This includes our live webinars that we do just about every week. For example, we're doing a webinar later today on how to document medical necessity in your SOAP notes. I think it's $129. If you're not a member of Target Coding, that's the fee. If you're a member of Target Coding, then there's no charge. Plus, you get CE credits for this one. And then we also offer a gold membership where you get more of a comprehensive review. You got ongoing trainings, unlimited question and answer support. You get our customizable forms, letters, templates, training manuals, free access to our seminars. And then we have something called our Platinum membership. This includes a full day of training at your office. If you're interested in learning more, we offer a free coding and compliance evaluation. It takes about 15 minutes. We'll go over any of your questions. We'll see if we could help you. Again, OIG and HIPAA are mandatory. If you don't want to use us, use someone else. Get it done. Audits are on the rise. Again, here's our contact information: email info@targetcoding.com, website targetcoding.com, telephone 1-800-270-7044, fax, our HIPAA secure fax number 1-844-831-2347. I want to thank everybody for attending. I hope you learned a lot.